Okay, so we're going to speak to the topic of major depressive disorder, and similar to what I did this morning in bipolar disorder, I'll highlight some of the newer treatments for consideration in our guidelines this time around. There are some new treatments that have been FDA approved. It truly is a unique time in the field. We're seeing a lot of change in the field, much needed. In the next 1 to 3 years, we're going to see some other new kids on the block. So innovation has finally found itself in the sentence of therapeutics and depression. So we'll say more about that. I forgot to mention this morning, it's my disclosures, different organizations I work with in the public and private sector who support my research. I'm not going to get too much into epidemiology of depression, and just to the point about pediatric mental health and mental illness, it certainly has been a pandemic of mental illness. For those who like statistics, again, about threefold increase in depression. When this pandemic started, I have a study going on in China. In fact, Wuhan was one of the sites. And I think we've come to learn that social and economic determinants played a critical role in risk and resiliency, especially younger people and females and those of lower economic position and economic insecurity were certainly more at risk. Just as in bipolar disorder, we are always reminding ourselves that this is an illness of above and below the neck. Really much could be said the same about major depressive disorder. This was a study we did where we discovered that if you have major depressive disorder or bipolar disorder, you're more prone to get COVID, and you're more prone to end up with complications from COVID that require hospitalization, and mortality is also higher. CDC prevention put depression, bipolar, and schizophrenia on the risk for COVID. It's just a reminder of the vulnerability with this condition. This is lethal, that being depression, losing not just years of life, but healthy years of life. One other aspect, again, I think we're all familiar with that's receiving long overdue attention, and something I was speaking about at a conference just last week is the pandemic of loneliness that exists around the world. That's a longer conversation. It certainly is an important conversation for what we're trying to do. Not only is it a vulnerability for people to declare depression, anxiety, have obesity, diabetes, but also suicide. And also there are a number of interventions that are specifically trying to target this. I can't say that we have an evidence-based strategy to address this issue specifically in depression or bipolar. This is a remarkably understudied area in the world of psychiatry. This was a study, a very low barrier to entry, low cost, high scale intervention, having college students reaching out to people on a Meals on Wheels roster in Texas, and showed over a very brief period of time, just some brief check-ins, that using the UCLA or the Jung loneliness scales, this would reduce loneliness and reduce depression and anxiety scores. So just something that I think has been amplified in interest during this time post-COVID. In major depressive disorder, like mental illness broadly, there's a pivot towards including, maybe prioritizing PROs, patient-reported outcomes, as a outcome measure in our depression therapeutics. DBSA, Depression Bipolar Support Alliance, we've had multi-year discussion with FDA and on how to define what wellness is in depression. And whatever it is, I guess we'll keep iterating and iterating, refining a definition. But I think all of us know firsthand as clinicians that when we take the PHQ-9 score below the cut for depression, that is, it's below 5, that doesn't equal health. And so the taketh away of depression doesn't equal health. And this has really been a larger conversation to think what this is, how to define this, and how we can treat it. And there's been a whole industry of measurement around this and trying to really document. This is all the positive mental health movement and so on. But this is very much a conversation in depression, because when we look at outcomes with antidepressants for the last 4 to 5 decades, on average, we've not seen with the monoamine-based drugs, we haven't seen a a saltatory move forward, a substantial move forward. As Rajiv mentioned this morning, placebo works better in the last 2 decades and it worked 3 to 4 decades ago, not only in schizophrenia, it seems, as I learned this morning, but also in depression. And so this is something that has been we need to consider this in how we interpret trials, but it's also something that I think, if anything, tells us we need to consider innovative treatment strategies. This is the famous STAR-D trial. It's 20 plus years old now, but this for me really resonates when we talk about a guideline for depression, because we have level 1, 2, 3, 4 treatment suggestions. And we know that as we go further down the levels, the probability of remission is lower. It's not hopeless. We still see a meaningful improvement, but the improvement in PROs really drops off considerably as we navigate down the different levels. A couple of comments about definitions, just to kind of food for thought this afternoon. The FDA on its website makes it very clear that the distinction between treatment-resistant depression and inadequate response to an antidepressant is one that is rather vague. It's not a clear line. In other words, how do we define treatment-resistant depression? The European FDA, known as the EMA, and the FDA have a similar definition. That is, a person with MDD who has failed 2 adequate dose, adequate duration, adequate adherence trials. That's a definition most familiar. There's over a half a dozen definitions, and just recently, on behalf of the World Psychiatry Association, we put together a global position on this, trying to define what inadequate response is in depression and what treatment resistance actually is. I think treatment resistance is something that pertains more to our monoamine-based drugs. I had a patient not too long ago who had been on over a dozen treatments. He drives a truck for a living. He's been off work. He's self-employed. Because of depression, he now has economic insecurity. And he received intravenous ketamine. And for the first time in years, he's better. And he didn't realize it, but he asked me a question afterwards where he was raving about how much he got his life back. And he asked whether he still has treatment-resistant depression. And I thought to myself, that question is, on one level, a fairly straightforward question to answer. But on a more abstract level, it's a very complex question. And so this is something that I think takes on a particular, for those who are interested in the interpretation of studies. We've seen more recently in December of 2022, cariprazine approved in major depression. That adds to aripiprazole, brexpiprazole, quetiapine as agents FDA approved as so-called adjunct or augmentation. Those drugs are all approved in people who have, in quotes, an inadequate response to antidepressants, but they're not approved in treatment-resistant depression. And I'll get more into this. It gets a little confusing very quickly. This morning, I just, in passing, very quickly mentioned that there's interest in terms of the scientific interest, the clinical interest, and drug discovery, drug development, or therapeutic discovery, therapeutic development, to look at treatments that are better suited to specific domains. Longer conversation for another day, but we've had this sort of bizarre concept or bizarre framework in psychiatry where we give people a treatment and we expect it's going to improve everything in their entire syndrome. As we know, in heart disease, people will receive a treatment for blood pressure, a treatment for heart congestive failure. There's different ways to approach chronic diseases, and no one expects one intervention to do it all. And it is the case that not only, for example, is cognitive impairment and anhedonia so common, but these are some of the more lingering features that we see in people treated with SSRIs, often comprise not just residual symptoms, but prodrome to the next episode. And this has become something that may, in fact, be a new indication in the future. These are 2 trials that looked at the outcome with SSRI treatment in individuals, and the investigators here looked at the baseline moderational effect of a proxy measure of anhedonia, the interest activity item from the MADRS or HAM-D17. And I guess the takeaway message is that the more fatigued, the more anhedonic, the more amotivated these patients are at baseline, the less likely they're going to respond to the SSRI, which almost seems bizarre to me because those are some of the key features, or at least key features that matter most from the point of view of PROs. So when we think about depression and we think about treatment, we encourage measurement-based care. We know fidelity is less than what it could be for measurement-based care. But as we think about outcomes, we have tried to bring some type of organization to this entropy, this chaos, by imposing some of these cut scores. We typically define non-response as less than 25% improvement on an intervention, a 25 to 50% improvement as a partial improvement. And again, but these are still kind of fuzzy. Someone might say, well, what's all the fuss about? Who cares? This just sounds like academic nonsense. What's the relevance? Well, we've been telling clinicians for a long time that if the patient starts an SSRI and after an adequate trial, the patient's not benefiting at all, they should stop that antidepressant and switch to something else. In contradistinction, if the patient has had some partial response or inadequate, but at least some response, then we should maybe augment. And this has been the teaching for quite a long time. And so that's one reason why trying to get this definition correct does matter. Now, with respect to this point I made earlier today, I find it quite shocking that such a low percentage of people go on to the next step. And perseverance is not just showing the world how courageous you are. Perseverance in this WHO study revealed that the outcomes aren't significantly improved. People often come to us after level 1, level 2 treatment in depression or bipolar, and they feel all hope is lost. And we understand where that's coming from in terms of their cognitive ways of processing and the black and white thinking and the negative prediction errors they make and so on. But clearly there is that advantage. And this is, I think, where the motivational interviewing comes in, the support, the psychoeducation, et cetera. Now, with respect to this question, I just wanted to bring you up to, these are some fairly recent or not too old reviews of the topic. The teaching that when a patient is taking an antidepressant and the option is presented, either stay longer on the antidepressant, say beyond 6 weeks, or switching to another antidepressant, there's not a lot of good evidence that really staying on the antidepressant is going to result in a better outcome. When I started in the field, the teaching was 8 to 12 weeks as an optimal trial. That's, some people still recommend that. I think we've really moved. This is a big shift to 4 to 6 weeks of an optimal trial. You don't seem to get more ROI beyond 6 weeks. And data suggests that switching out after 6 weeks may be more advantageous. The other sort of base guiding principle about dose optimization needs to be just revisited again, in the sense that we encourage people to optimize the dose within the package inserts for each of the available antidepressants. For the SSRIs, we don't really have a dose response curve. In other words, we don't have a data to show that if you increase the dose of the SSRI, you get more therapeutic effect. We do see a dose response curve for venlafaxine, but you also see a higher rate of dropout due to adverse events as you increase the dose. Vortioxetine is one that when you increase the dose, you don't see more dropout. So taken together, the only drugs that we have in the antidepressant arsenal that have dose response curves are venlafaxine, vortioxetine, and mirtazapine. Notwithstanding, we still continue to recommend dose optimization, as there are clearly individuals within larger samples that do show dose response curves. Now, I want to draw everyone's attention, if I could, to the square on the right-hand side. It says adjuncts to first-line agents. And we here today are trying to help our colleagues make decisions at the point of care, decisions that have that are cost-effective but are really helpful and safe. And we are reminded yet again of the implementation gap. In other words, the gap between what we know we should be doing, what's actually happening. And this was a study where they looked at what was the most common adjunctive strategy given to someone who has had inadequate response to the first-line antidepressant. Well, the most frequent strategy was adding a benzo. So that's obviously a call to action. Adding antidepressants together has become very popular, mirtazapine, bupropion. But interestingly enough, that combination is not as studied as many people think it is. We don't actually have large randomized double-blind placebo-controlled trials. We have STAR-D, we have some smaller controlled trials. I'm going to show you some new data in a moment that really begins to suggest that the antipsychotic add-on may have an advantage over the antidepressant add-on without the marks lost because of tolerability. I'm going to show you some interesting new data just published in a moment. So as far as FDA approvals go with respect to what's been proven to be effective and FDA endorsed, olanzapine fluoxetine is approved in TRD, treatment-resistant depression. Just a reminder, esketamine is approved in treatment-resistant depression. It's also approved in adults with depression in suicidal ideation behavior. Aripiprazole, brexpiprazole, and more recently, I should add, cariprazine. Cariprazine's in my middle column. So cariprazine is now, if you will, been upgraded, or whatever the phrase is. It's now been approved as of December 2022 by FDA. So all ABCs, aripiprazole, brexpiprazole, cariprazine, all the dopamine partial agonists are approved as augmentation in depression, and the quetiapine XR moiety is also approved. And all four, the ABCs and quetiapine XR, are approved in patients with MDD and an inadequate response. I mentioned in passing this morning that lumateperone's now been studied in unipolar depression in a mixed study of mixed patients, and lurazidone's been studied in mixed depression, but it doesn't have FDA approval. I think a couple of comments. I think where the atypicals have been especially welcomed is their ability, yes, to treat depression, but also to treat these lingering symptoms of anhedonia, rumination, anxious agitation. And we're seeing that not just with the aripiprazoles, brexpiprazoles, but also cariprazine. It's a pretty consistent finding we see with these agents. Now, I want to show you the results of two trials that I know you'll be interested in seeing. One was just published about a month ago in the New England Journal of Medicine that don't give us the final word. They're not the final word, but they are beginning to give us some data points in the conversation. This is the most common fork in the road clinical decision point clinicians are scratching their head with. A patient has MDD. They start off with an SSRI because that's what their formulary allows them to take. And the patient has an inadequate response. So do they add bupropion to that, or should they just stop the SSRI and switch to bupropion, or should they add a second generation antipsychotic, in this case, aripiprazole? This was a study called the FAST study. It was a VA study. 85% of the subjects were male, so keep that in mind. I'll give you the skinny. The skinny is that the add-on approaches beat the switch approach. So the add-on approach of either the antidepressant or the second generation antipsychotic beats switching to a separate monotherapeutic antidepressant, whether you're looking at response, remission, overall improvement. Now, the study wasn't adequately powered to really compare bupropion to aripiprazole as the add-on, but there's a trend, and only a trend, that was in favor of aripiprazole beating bupropion without more adverse events leading to dropout. Sorry for the very small font. I apologize. It's come up small for some reason on my slide. But this was a study just published in the New England Journal of Medicine. It's effectively identical in some respects. It's a study, but this was in geriatric depression. And these are people with more resistant depression, and they're on an antidepressant. They are then either switched to bupropion or added bupropion or added aripiprazole. And the outcome measure was kind of a wellness measure more than a depression measure. This was a PCORI-funded study. In this PCORI-funded study, again, the add-on approach beats the switch to monotherapy. So that's 2 for 2. And again, not powered sufficiently to really compare bupropion to aripiprazole add-on, but it looks as though the aripiprazole add-on was the slight winner with respect to efficacy without losing marks on tolerability, leading to discontinuation. So again, I don't think it's the final word, and I appreciate there's many parts of limitation to this, and no one's going to make a strong statement. But we certainly are seeing now, I think, some 2 compelling study results showing add-on approaches are beating the switch, at least this FDA-approved approach for the second generation. This was a paper that caught my eye last summer in the World Psychiatric Association journal. What they found was, this was a study from Denmark, that low-dose quetiapine, 25 to 50 milligrams, which is commonly prescribed in psychiatry just for non-specific reasons, sleep, anxiety, agitation. You don't get a free lunch here. A lot of people think that's, no side effects and so on. This was, again, a large nationwide registry. So this is more perspective than precision, showing an increase in the rate of cerebral vascular and cardiovascular events in quetiapine exposed individuals, even at the low dose. I bring it up for a couple of reasons. First of all, we don't use quetiapine as much as the adjunct because of the weight gain and the sedation and the diabetes risk. But also, I think it's a bit of a perception. And one of the perceptions is many colleagues are seeing antipsychotics as having more side effects than would be adding an antidepressant. But I think that it's going to depend very much on which adverse event we're talking about. I showed this earlier. Ketamine, an IV ketamine, racemic, esketamine intranasal spray have been breakthrough treatments for us. A study just finished, I don't even have the slide for it, was a study that compared esketamine to quetiapine XR in depression as the add-on approach, not just for short-term acute, but also maintenance, and esketamine's the winner. And what's not well known is that esketamine has 4 years of prospective data. We don't have any long-term data for any second-generation antipsychotic in MDD. So esketamine, its implementation, I know across the country has been patchy because of access and reimbursement. Scope of practice, core competencies, et cetera. But I just wanted to bring that up. And I'm always asked which one's more effective, intranasal or intravenous? And the answer is we just don't know. These are apples and oranges methodologically. We have not been able to say one way or the other. And this is really critical because we get calls all the time from payers saying, what should we be paying for? How should we tier this? Because IV ketamine, racemic, not in all, but many jurisdictions, is less expensive in acquisition than would be the Spravato treatment. And so on the efficacy side of that determination, we just don't have yet enough evidence to say both are appearing effective. But you all know that when we are talking about depression, that becomes a talk about suicidality. Of course, depression and suicidality are not identical, but depression is the condition most often associated with suicidality, and so is treatment-resistant depression. These things overlap considerably. And when it comes to esketamine, also has this evidence. So since the last time we met, in March of 2019, esketamine was approved for TRD. And in August of 2020, after our last in-person meeting, it had an update where it was approved for suicidality. And again, that's not TRD, but these are depression with suicide. And the anti-suicide effects of esketamine and ketamine in MDD have been highly replicated. The question, of course, is can it decrease suicide? And that's to be determined. And there's ways where we're trying to prolong the effect of esketamine and ketamine in patients. And that's work that's ongoing. I just wonder if I could just touch on very quickly some aspects about psychedelics, because you've all been hearing about this. It's all over the newspapers. It seems like it's become a hot topic with Reddit and Facebook and all these social media places. Just to put it in this typology, MDMA, methylene dioxymethamphetamine, was discovered by Merck Pharma back in 1912. It was a drug for coagulation disturbance, didn't quite work, got shelved, and it got taken off the shelf five decades later as a facilitator for psychotherapy. I just covered ketamine, esketamine very, very quickly, and we'll come back to dextromethorphan shortly, but psilocybin is part of the classic 5-HT2 agonist. But before I really speak to that, I want to just maybe not forget to mention rapid onset antidepressants. So we've moved into a very new language where since I've been around, since all of us have been around, we just expect 4 to 6 weeks for antidepressants to work. Well, esketamine and ketamine work within a day. Some require longer, but on average, they work very rapidly. And when we think about rapid onset of antidepressant action, we think about glutamate, we think about GABA, which I'm going to cover in a moment, and we think about 5-HT2A agonism. And psilocybin has received the most attention. It's, of course, one of many tryptamine derivatives. And there was a study that generated a lot of hype in the New England Journal back in 2021, where there was some benefit that was shown in a very small group of patients. It was inadequately powered to compare it to escitalopram, but certainly, in fact, showed benefit not dissimilar. This paper appeared in the New England Journal of November of last fall. This was a single dose of 25 milligrams of psilocybin in adults with treatment-resistant depression with rapid onset effects that were sustained out to a period of time. And I should mention that this is along with supportive psychotherapy or so-called integrative psychotherapy. So the psilocybin has found itself moving into phase 3 now. There's a couple of sponsors of this program. I know there's been a lot of hype around this. And usually with hype, there's often silliness, but there's also something real. And I think we're still trying to figure out where that line is in this field. But certainly psilocybin is looking promising, but it's not certainly at all ready to be recommended until we see phase 3 studies. Now, I just wanted to share with you just some other directions the field's taken. This is just for your interest. Orexin antagonists are drugs for insomnia, and orexin antagonists have 4 principal effects on the human behavior. One is sleep-wake. That's why they're used as sleeping aids. But they also affect stress response. They affect reward activity. And they also affect appetite. Inseltorexin is a orexin antagonist under development for depression, and that's in late phase 3, not quite here yet. Auvelity was approved fairly recently. In fact, just last summer in August, the FDA approved the combination of dextromethorphan bupropion as a new NMDA antagonist, sigma-1 agonist, rapid onset acting antidepressant, a 1-week separation from placebo. And this is a new entity. And again, they're not new drugs, but this is a new entity brought together. And the first time the FDA has approved a non-monoaminergic oral antidepressant in depression. Brexanolone, we've chatted about before. It's been approved previously for postpartum depression. In August of this year, the FDA is going to make a decision on whether to approve zuranolone, its sister, for major depression. And this is an antidepressant, if it's approved on August 5th, actually, if it's approved, will be the first PRN antidepressant. So you would take this for a script up for 2 weeks. The drug begins to separate from placebo after just 3 to 4 days. So that's eagerly awaited, but it's not quite here yet. But just something, Marie, we can discuss that. I mean, maybe if there's a way to update our guidelines if needed. But this is going to generate a lot of interest, and it's a GABAergic rapid-acting antidepressant. Esketamine is a glutamatergic rapid-acting antidepressant, and psilocybin is a investigational rapid-acting 5-HT2 agonist. More for your interest, these are kappa opioid receptor antagonists that are now in late phase 3, being developed for depression. And the aim is not just to improve depression, but also to improve measures of anhedonia. S-methadone, this is an isomer of the racemic molecule methadone. This is a non-opioid ergic agent that's an NMDA, uncompetitive antagonist, is also in phase 3. So it's just an exciting time of treatments that we have that are in investigation. Now, this is not investigation. This was cleared by the FDA last September. This is the very first time in psychiatry the FDA has approved a therapeutic in psychiatry that involves radiology. So this is MRI-guided rapid TMS, or a rapid protocol for TMS, where rather than patients coming each day for 6 weeks, the patient spends the entire day in the clinic for up to 10 sessions a day for 5 days. And it's called the SAINT protocol. It seems very, very saintly in the sense that it gets patients better rapidly in a week, and with response rates approaching 62 to 69%. And that can be sustained out for 4 weeks. And you can see the remission rates here that are quite significant. Now, the $1 million question is always going to be longer term data. These are small samples, et cetera. But it's a kind of an interesting footnote in psychiatry. The first time radiology has been included in terms of a therapeutic in psychiatry. But of course, lots of questions are going to emerge as to the availability of this. How much does the MRI really help out? Can you just, and I can tell you the answer is about a 20% extra return on the investment. We can discuss whether that's worthwhile and so on. We talked about ketamine already. This was a study we did, Greg Rhea and I did, we published in JAMA looking at comparing ECT to ketamine in patients with depression. And I would say that the jury is still out because we don't have all the data points yet. But like always, we're always trying to eavesdrop on the jury to see how the deliberations are going. No verdict yet, but right now ECT seems to have a slight lead on IV ketamine, perhaps even more so in elderly populations. But I don't want to make it sound as though that's the final word. Both treatments are highly effective. Obviously, IV ketamine doesn't have the cognitive problems. Now, psychotherapy that's protocolized is a recommended treatment in MDD, mild, moderate. We don't have good data that it's effective on its own in TRD, but we do have data that when it's added to antidepressants can help patients. And I think we've all become very familiar during the pandemic, of course, before the pandemic, but it took off during the pandemic with the online CBT. And it turns out that the short story is that these types of online psychosocial interventions for depression, especially when they're guided, are resulting in outcomes, acceptability, as good, if not better, than seeing a therapist in person. And there are cost advantages for many people. Of course, there's an assumption you have availability to Wi-Fi. There is a legitimate question raised, however, about attrition and engagement, which is a major problem with everything online. And I suspect that's why the guided treatments are doing a little bit better than the non-guided treatments. So just a kind of a tour of just different things, a little sampling before we get through some of these guidelines. But I think, in fact, to summarize, where we've had new entries is Auvelity. We've had new entry with respect to S-ketamine and its suicidality overlapping with depression. That's depression with suicidality. We've had the update to Vraylar in major depressive disorder. We've had the SAINT protocol and its update with respect to rapid acting activity. And we also have now, I think, a really wealth of data documenting the efficacy, the acceptability, the cost effectiveness of the protocolized online guided CBTs. So I'll just stop there.